It's great to have you with us. It's a real privilege to be here on the first day of the inaugural INPCS conference, and we're really grateful to the organisers for inviting us here. So this session's going to take the form of 3 pre-recorded interviews where we'll explore some of the issues around the practical delivery of neuropalliative care. We'll then have 15 minutes at the end where we will draw out some of the issues from those interviews and also answer any questions that you have posed to us. So if you could pop questions in the Q&A box as we go along, then I'll try and moderate those and present them to the panelists. We're really grateful for your attention and hope you enjoy the videos, which will start shortly. So it's a great pleasure to introduce Dr. Joel Phillips. He's the Regional Medical Director for Palliative and Supportive Care at Trinity Health, West Michigan. And his neuropalliative care is through the Hauenstein Neuroscience Center. So Joel, thanks so much for joining us.
Thanks for having me here.
Can we start just by asking quite a general question, just to understand a bit about what you do in your day job?
Yeah. So through the Neuropalliative Care clinic, I do see a lot of different patients coming through. I kind of define my patient population as all comers for neurodegenerative diseases. So I do see a lot of patients with ALS, with Parkinson's disease, MS, some myasthenia, and other neuromuscular disorders. Within ALS, I'm embedded in that clinic, and it's a multidisciplinary clinic. With some of the other patients, such as Parkinson's, the visits are a little bit different, where we do have, it's more of a regular neurology visit, but we do have access to other supportive services right within the clinic. I would say that a lot of that is based on the uniqueness of the clinic that we have. Back at its inception, the idea was to start out by creating a clinic where patients with Parkinson's and other movement disorders in particular could get all the supportive services they needed. So it did start with one movement disorders neurologist, and then that actually, along with that, had a physical therapist join him, and that kind of budded and blossomed and grew into the neuroscience center we have. Now we have embedded PT, OT, speech therapy, social work as well, all within the clinic, even before palliative medicine came on board. So it's really kind of the right culture to begin a neuropalliative care clinic.
That's fab. And so with that interesting mix of different patients, what would you think your observations are about the main differences between the way you would provide neuropalliative care, say for someone with PD versus someone for ALS?
Mm-hmm. Yeah, and I think a lot of it really depends on the trajectory of the disease, and looking at the natural history of the disease dictates a good way of approaching it from that palliative perspective. With ALS, there's anticipated trajectory. You know that the time course is going to be shorter, and you can address a lot of things in a predictable sort of manner. Oftentimes we're talking with anticipatory guidance, talking about non-invasive ventilator before it becomes needed. We're talking about the PEG tube before it becomes needed. Just having a lot of those talks because we know that eventually it's going to kind of go down that road. Within the ALS community, a lot of the clinics are multidisciplinary already and do have a lot of services embedded within that clinic. So that does help us as well. From that Parkinson's standpoint, we kind of have that same sort of idea of what to expect coming down the road, but things may be a little bit more long and protracted. So often we may start with more of an introductory sort of a conversation of what is palliative care, why am I getting involved in your care, and really addressing a lot of the symptoms up front, maybe talking a little bit about that prognosis, making sure patients have an understanding of the disease, and then having more regular follow-ups to discuss things as patients progress. As function declines, as new symptoms arise, we can address those as we go on. And some of those patients I've seen for several years at this point and continue those conversations. And they just kind of evolve as the patient's needs evolve.
How would you, because from your paper regarding ALS setups in the US, people had a reasonably standard sort of follow-up regimen of around 3 months.
Mhm.
With the PD patients with the longer trajectory, how would you negotiate the frequency of follow-up, say? Would that be a standard approach? Is it something negotiated with the patient? Is it entirely needs directed? And in which case, what are the stepping on points?
Yeah. So oftentimes, just to kind of give a little bit of background to that, first of all, I work very closely with the movement doctors, and a lot of the referrals are probably when we're starting to see more needs come on, would kind of be generally the case. So as I'm taking on a patient, I may follow up more regularly with those every 3-month follow-ups, just because there's so much to address up front. So have that introductory sort of talk and then address a lot of things. Maybe we deal more with some of the non-motor symptoms on the next visit. And by that following visit, we might be diving into some of those goals of care conversations, at least getting advanced directives talked about, code status talked about, and starting those conversations. But as we go out after 2 or 3 visits, we may say, you know, things are really stable here. You're looking really good. Let's push that out to 6 months. Or if things are progressing more rapidly than we thought, or when patients do get to that point where disease is more advanced, I may see patients on a monthly basis where we say there's just so much that needs to be aggressively addressed. Let's see you back next month again. Within that, I do have the ability on rare occasions to get into the home as well, which I'm kind of spoiled in that role. I have to admit that I've got the opportunity to do that. But sometimes when the patients aren't able to get out, I'm able to do more of those home visits, really assess the home environment and talk further about goals. And usually by that point, we may be talking about transitions to hospice.
That's really interesting. Thank you. And during that time, would they be seeing the neurologist who originally saw them for their PD as well, or would they see you solely in both the neuro and the palliative role?
That's a good question. Starting out, what we do is more of a model of co-management, which may actually affect the frequency that they see me as well. Usually there's still enough that needs to be managed as far as Cinemet and some of the other kind of motor medications that, or they're still titrating the DBS or adjusting those things. So they will often see their movement disorders specialist and then see me in kind of, I won't say in tandem, not the same day, but kind of along the same timeline or trajectory. But usually as patients get more advanced, I have a conversation with the movement disorders physician, and we'll usually transfer care over to the Neuropalliative Care clinic, and they'll probably step back from seeing the movement disorder specialist at that time. And at that point, we're really dealing with a lot of complex symptoms, and a lot of the medications or interventions a movement doc may be using are not as effective as they were earlier on in the disease. And then that really helps us with that transition talk more about some of those palliative needs, and that often does help lead to more transitions into hospice as we go on.
Great, thank you. So I just wonder, with the transitions, not just for folks with PD, but for other diseases as well, to what extent, if any, do you see a role for assessment tools in trying to aid that process? Or do you think that should be more of a feel and clinical feel as we go along?
Yeah. So I'd say the first answer is clinical feel is most important. Kind of assessing the patient, getting that gut feeling, I feel is going to get you far. In my clinic, I am assessing the PPS, the palliative prognostic score on every visit, more so I can kind of gauge where I think patients are. I find that one of the most helpful ones because it really describes function. So along with that, in the cancer realm, we do know that there's prognosis tied to that. I find that less helpful in this case based on our patient population. A lot of our patients will be hitting the PPS scores of between 40 and 60 very, very easily, and they're going to live for a long time with those low functioning scores. But it best kind of gives a number and helps describe that functionality. Along with it, I am doing this Edmonton Symptom Assessment Scale, to gauge the symptoms that patients are having. I've really found the ESAS-PD helpful as well for the Parkinson's patients. And just based on literature I was doing kind of earlier on, what I had been reading, a lot of the palliative scores for MS had been through the palliative outcome scale. So I am still using the palliative outcome scale just to be a little bit more consistent with some of that initial literature I read several years ago.
That's really interesting. So thank you. I guess particularly as some of those tools start to develop disease-specific tag-ons, if you like, I guess that role potentially grows. But it's interesting to know how, if at all, people integrate that into their practice, right, rather than using it in a research sense.
Right.
And so I guess moving on from those aspects and thinking a bit about how people flow through a service, I just think it'd be interesting to touch on some of the other key points. I mean, in terms of identification, for example, of patients who are appropriate for the clinic, and then perhaps gatekeeping that clinic if there's more patients that are suitable than you have space for. How do you manage that?
Yeah. So one thing that I've actually found is that when my colleagues hear palliative medicine, first of all, I know a lot of people think, oh, that means hospice. But on the other end of that, people may think, oh, pain management. This doctor knows a lot of what to do for complex chronic pain. So that's probably, as referrals come in, one of the biggest things I need to filter out is that complex pain. Now, on a case-by-case basis for peripheral neuropathy or trigeminal neuralgia, we may see some of that. I limit a lot of my pain consults to things like central pain related to stroke, spinal cord injury, phantom limb pain, some things that are more specifically neurologically based, where their patients may be better served for other pain issues like chronic back pain in a spine clinic or something that's already established in that realm. So I try to define my role again more as that chronic neurodegenerative disease clinic, and defining that really has come down to talking with my primary referrers, so our neuromuscular docs, our movement disorders docs, so they have a good idea of when it would be appropriate for me. So it's a lot of those conversations up front. At the same time, I've found that going to community support groups, we've got a grassroots ALS association or ALS support group that really does a great job of getting families together and talking about these sort of diseases. We've got Parkinson's support groups. When I get in there and talk about palliative care to patients and families in that realm, I find that a lot of patients say, hey, you know what, that sounds like what I want to do. And they'll talk to their neurologist and we'll get something set up. So I am starting to see referrals come in from other health systems as well as the word gets out in the region of what it is we do here. It's getting more recognized, and we're seeing that referral base almost grow, just based more on word of mouth and kind of getting out there to talk with patients directly.
Thanks. And we talked just before we started recording a little bit about the possibility of dual assessments, or seeing different specialists on the same day versus different days. And I think particularly in the States that can be influenced a bit by how you bill for clinics and how you pay for clinics. Is that something that is important for you?
Yeah. So that's something that comes into play every day. A lot of times within the billing system here in the United States, we cannot bill a patient to see two separate neurologists on the same day. They have to be seen on different days in order to get the billing done. So oftentimes they'll see their primary neurologist one day and come in and see me a couple weeks later or the next day, something along those lines. I know that there are a few other people in the country who are having the palliative neurologist bill as palliative care. And that's one way of kind of circumventing that, or allowing patients to see the neurologist and the palliative neurologist in the same day. Where it really becomes more of an issue is what's going to be best for the patient, because there is that convenience factor where the patient can see both doctors on the same day. They don't have to come into the clinic twice. But on the same hand, we know that a lot of the conversations can be very long, very emotionally taxing and fatiguing in themselves. So we run into this issue of, if we're going to see each other on the same day, will we have an effective meeting? Is it going to be something that's going to be productive for the patient, or is it something that's really going to be more bothersome? And would it be better if they do come back on another day? So it's really that balance of how can we best serve that patient.
Yeah, it's really interesting, isn't it? Especially as people age with their disease, maybe have multimorbidity. And these are issues that we have in geriatrics in the UK and trying to organise our clinics. So it's very familiar. Just as we draw things to a close, do you have a couple of top tips for someone looking to set up a service?
Yeah. Well, again, I want to say I was spoiled with the clinic I found, and a lot of things were just set up to get the service up and running. I think the biggest thing is finding ways to get the support you need into your clinic. So a lot of things that we have set up here are through philanthropy. So we've got a lot of grant funding. We've got a lot of donors in the area who see the importance of having all of these services available for patients. And so a lot of that we can't bill through insurance. So philanthropy is probably one of the big things. But also, I would say, talk with the neurologists in the area, kind of ask them what they're looking for. Tell them what you can actually do for them and how you approach things differently. I know the biggest thing when I started out and told my training faculty, when I told them I wanted to go into palliative care, they said, we're neurologists. We're all palliative care doctors. That's what we do. We palliate the patient. But really getting the word out that we as palliative care are doing much more than that primary palliative care, but really getting into the specialized, highly complex symptom management and really delving deeper into goals of care, and allowing for that time to be able to talk about these things that might not be allowed in a regular neurology visit. So we take it to that next level.
Brilliant. And then just finally, one dream development, one thing that you'd like to see change.
For me, my dream has always been to get into the community and try to get community-based neuropalliative care set up. The few times that I am able to get out into the clinic or out from the clinic into the homes has been very eye-opening as to seeing what patients deal with on a day-to-day basis, and really can help me better assess and better take care of them. So my goal going forward is really to make that more of a reality. I know that there's a convenience factor with telemedicine as well, but it's not quite the same as getting into the house. So that's where I would like to see things go.
Brilliant. Joel, thank you very so much for your time. Please, people listening, do pop your questions in the question box, and we'll have time to address those in the Q&A later. Thank you. So I'm really pleased to be able to introduce Dr. Clare Ellis-Smith. She's a lecturer in palliative care at Cicely Saunders Institute at King College London in the UK. She trained clinically as an OT, has clinical experience in the care of older people with dementia. Amongst other things, she's currently working on the EMBED programme, improving palliative care for people with dementia in the UK. So Claire, welcome. Thank you very much for coming to speak with us.
Thank you, and thank you for the invitation.
I wonder if we could start off with a broad question, just thinking about palliative care for dementia and what the particular challenges might be.
I think one of the main challenges is that obviously there's a huge growing population of people with dementia. And we know that people with dementia, even from fairly early on in the disease trajectory, but as the disease progresses, have palliative care needs, including symptoms and concerns related to dementia, but also often due to comorbidities common in old age. So there's a real challenge in how we provide palliative care to this growing population who may be at high need, who live long with dementia. So there's a real demand for palliative care, and we really don't have models of care to know that we know best how to address this growing need for all those who may have palliative care needs.
So thank you. It strikes me, even in Parkinson's disease, where the population is much smaller, when I'm speaking to palliative care colleagues about how to establish an integrated service, the big worry is the number of people who potentially would be eligible, and particularly at a time when we're looking to extend palliative care to other non-malignant conditions. And people with dementia, I think, make up potentially a huge number of those folks, both through their comorbidities, but also through the dementia itself. And I think that forms quite a barrier to actually producing integrated care in practice, because our colleagues who are thin on the ground are already very worried about how they can continue to manage their services sustainably. How do you feel about that?
Yeah, I completely agree, and I don't think it's realistic to expect, or I don't think it's necessary that every person with dementia necessarily needs specialist palliative care. What we do need is a skilled workforce who are able to identify where those palliative care needs are. Often are able to address these because they're not complex to address, but also to know when to refer to more specialist services. So we need to develop models of care or interventions that really skill all those workers who commonly work with people with dementia. And by that, I mean health and social care professionals. So in the UK, that might be people who work in care homes, it may be primary health care professionals or community care. But those are the people with dementia normally are cared for, not specialist dementia or specialist palliative care. And those are the models of care that we need to develop to support a provision of palliative care. And I'm quite keen on developing very simple, easy to use interventions that can support more generous providers to provide palliative care.
Thank you. So I think, I think we're of one mind, and I'm sure most people listening to us would agree. And these models, which rely on primary palliative care, or what we might call palliative approach in the UK, to meet most of the unmet need, with recourse to specialist palliative care on a symptom by symptom basis, I think is what we're talking about. And the thing that seems to be quite common to those proposed models is really this interface between primary palliative care and specialist palliative care, or chronic care, if we call that, in the community, versus specialist palliative care, and the interface between them. How do you see that being managed for people with dementia?
I think it's a huge question, isn't it? And one that's at a system level that's not necessarily easy to change, particularly when, certainly in the UK, every local service may be set up slightly differently, and so we need to find ways that can work well within different systems and different setups and different services. As I referred to before, I think often developing simple interventions that can work between different providers to facilitate integrated working is often key. So if you can develop an intervention which can, in a sense, provide a shared language or a shared way of communicating, you go a long way to supporting integrated working. And a lot of the work that we're doing at the moment, and particularly on the Embed Care program, is developing a complex intervention that both supports comprehensive assessments of palliative care needs in people with dementia, but also supports integrated working by providing a shared language and providing tools for shared decision making based on best practice.
So that's really great to hear about. It would be lovely to hear a little bit more about the Embed program, if that's something you're able to share.
Of course, yes. So the Embed Care program is a 5-year program, research program funded by the ESRC, so the Economic and Social Research Council, and the NIHR. And it's the Embed Care program stands for Empowering Better End-of-Life Dementia Care. It's led by Professor Liz Sampson at University College London and Professor Catherine Evans at King's College London are the two chief investigators. It's a 5-year program. It comprises 6 work streams, which culminates in the Embed Care intervention. The Embed Care intervention is a comprehensive assessment, which is the Integrated Palliative Care Outcome Scale for Dementia. And it's an assessment measure of common symptoms and concerns in people with dementia, also living with multimorbidities. Those link or create an alert to evidence-based best practice decision support tools to support management of symptoms and concerns. And we're developing it to be delivered through a telehealth app so that actually people can do an electronic assessment. And the assessment is supposed to be able to be used across settings to support integrated working, so that the person with dementia, when they're able, can self-report their symptoms and concerns, or the family carer can report symptoms or concerns, or the care home staff member can complete the IPOS-DEM to identify symptoms and concerns. So it's used in care homes, but also for people living in their own homes.
Thank you very much. That sounds really exciting. And I guess you're 2 or 3 years into that project so far, is that right?
Yes, yeah, we're a little bit more than halfway. So we're now co-designing the intervention with expert stakeholders, including people with dementia, their family carers, and health and social care professionals from all different backgrounds who work with people with dementia. And then the final work stream 6, is feasibility and pilot testing, where we will test the intervention, its acceptability, and then do a pilot study to test the methods for a full cluster trial.
Super. I look forward to hearing about that. It sounds like a real game changer. Could I touch on, I think it's a bit of a shared passion of ours, based on our earlier discussion, about tools and assessment tools for palliative care needs in people with dementia. I suppose it seems that tools could have a role in case finding to try and help us navigate that chronic palliative interface, but also in quantification so that we can assess response to interventions. Do you think a single tool can do those things? Do you think we need different tools for different parts of the process?
I think we need to keep things as simple as possible. And I think where possible, a single tool is better than multiple tools, but no single tool is going to be right for everyone. But it's also how we use the tool and how tools are integrated into care. And I think a key purpose of the tool is a tool can be done just for the sake of it and not change care in any way. But with the right training, and if people understand how tools can support care, tools can change the way care is provided. What we've learned both through kind of our feasibility work, through previous research, and also through some audit work where clinical teams have used the IPOS-DEM in routine care is that using a tool on its own can support identification of symptoms and concerns and needs. They can support more facilitated they can facilitate communication by providing a shared language. They can facilitate communication between family members and staff and people with dementia and staff. And can empower people. They can provide people with a language to communicate their needs that they may not have had before. So there is some evidence, and we're certainly building the evidence that a tool can, in of itself, change care. But it does depend on how it's used, and also I think importantly how it's implemented. I think there does need to be some flexibility in terms of how they're implemented, so that teams can make tools work for them rather than being dictated to by the process of using a tool. So certainly different teams have used tools in different ways. Some use tools in handover meetings. Some find using an assessment tool supports opening up a dialogue with people with dementia and being able to ask them about symptoms and concerns they may not have had in the past. So from our work with the IPOS-DEM, yes, if used correctly and with the right supports, they probably can change care, but there's always a risk that they don't if they're not used correctly, and they certainly need to be used flexibly within existing care processes so that they're not duplicating work and they're not providing a burden to staff.
Thank you very much. I think it's a really interesting area, and maybe we can draw it out in the Q&A, because I wonder, particularly with dementia, where I feel as though the downstream services that develop are likely to be very heterogeneous because of the nature of how we provide care and how it's paid for. And actually the idea that the assessment, the structured and rigorously applied assessments might be as much the intervention in terms of the thing that makes a difference, allows then those services to grow organically rather than being dictated very, very, very tight about how the service should look.
Yeah, absolutely. And I think, you know, there are obviously other benefits to using these tools in terms of on an individual level, in terms of informing care, but also on a service level, that actually if you collect that data, you can show the complexity of needs of the population you're looking after. You can potentially, and certainly some of the services worked with have been able to show that they are able to provide change in the needs of people with dementia through using that structured assessment. They use the assessment, then they change care plans, and then they reassess afterwards. So there are benefits on an individual, but obviously also on a service level.
Thank you so much. It's flown by. It's been really fascinating speaking to you. We're going to try and draw out some of the points in the Q&A as well. For a last question to spring on you, what would be your dream development in this area of practice? If you could develop one aspect, what would it be?
I think for me the real priority would be where we got to a point where palliative care was seen and understood as everybody's business, and that it wasn't seen that actually that people felt skilled and enabled and empowered to be able to identify needs and support the management of symptoms and concerns. And I guess kind of what the real, for me, one of the huge challenges is that care does truly become person-centered. And I guess always with services, there's a risk and there's a challenge that they tend to be quite process-driven. But if we could really, really be driven by the priorities and needs of our population and address those, that would be amazing.
Thanks ever so much. I really appreciate you taking the time to speak to us today. Do remember, everybody, to pop your questions in the Q&A box, and then at the end of these recorded segments, we'll have a chance to look at some of these issues in more detail. Thank you ever so much, Claire.